Welcome back to Morning Coffee. I'm Jim Cuccinata, and today I'm doing a double. We have our true legislative expert on the medical field with us today, Dr. Alieta, and today we're going to talk about Medicaid and kind of narcotic abuse, I guess is for kind
That's
of the
right.
lack of better term. So welcome back.
Hi, thanks for having me again.
Yeah, nice to see you. So let's start with right into it. From the jump. Tell me about
What's
Medicaid.
going on?
Yeah.
Medicaid. Well, my husband and I operate a non-government free clinic in Somerset called the Zarephath Health Center. And we've learned a lot about Medicaid, largely that a lot of people can't find a physician. And so half the people we see at our free clinic are on Medicaid. Medicaid's good for medicines. If we write prescriptions, those prescriptions will get filled, but they can't find a physician. And mostly the big gaps are psychiatry, pain control, and elective surgery.
Okay.
So we'll see a fellow come in with a knee that has shrapnel in it, and he can't find a doctor that will take the shrapnel out of his knee, so he's in pain.
Right.
He also can't find a pain control physician, so what does he do?
Right.
And often these people, they're poor, they're struggling, and they don't need a physician to get heroin.
Right.
So that's where they might get their pain medicine, and it's very, very sad.
Right.
I just think we could do so much better.
Sure. So it's the system, right? It was interesting because I was thinking of the kind of the flip side of the Medicaid to make the person go away. They're getting overprescribed, but it's actually they can't find somebody to prescribe them, so they're actually looking for illegal narcotics to kind of ease the pain,
That's
which
part
is
of the
even
problem.
worse.
Yeah, and they just passed a law in New Jersey, which doesn't surprise me because I think the legislators, they do feel good legislation.
Yeah.
And one is that doctors can't write a prescription for more than 5 days worth of pain medicine at a time, unless it's chronic. And so, I mean, it's good. We shouldn't give too much medicine for something that's going to be short-lived.
Right.
But on the other side of it are the people who are just really struggling. I saw a woman just this week who I've been taking care of because she had an injury to her jaw when she had dental surgery over 2 years ago. And the pain that she developed was so severe that 2 years ago she tried to commit suicide because she couldn't get pain relief.
Right.
And she's been to specialist after specialist. She's been up to Newark. And she had one doctor who was going to do a procedure for her, and then they discovered that they don't take that type of Medicaid. There's Medicaid HMOs. So it was canceled. And meanwhile, she comes to us, and again, she can't find a pain control doctor.
Right.
So she can't find a surgeon to do the fix, or whatever it would be that would ablate that nerve that's causing the pain. And the struggle and the pain that she goes through is incredible. It's well as psychiatric pain because it's just, you can't imagine what it's like to be in constant pain.
Exactly.
And we come and we'll help her, and I will prescribe medicine that will cover her pain. And fortunately, because we're in that clinic, the federal government helps us, and it provides us malpractice coverage for what we do in the clinic.
Right.
So it makes me a little bit more able to not fear giving medicine that's really going to help. I'm careful though. You know, there are people that just want drugs that'll come in. I have to screen them carefully.
Absolutely.
And there are ways of doing that. We've learned, how to pick the ones who are gaming the system and those who really do need pain relief. I'm thinking, we have a Medicaid system. In New Jersey, we're spending $15 billion on Medicaid.
Right.
Our whole budget is $34 billion. Think about that. And why can't we come up with something that will really help the people need it?
Exactly. And in theory, right, that's what Medicaid was supposed to do, right? It was supposed to help the people that really don't have great access to care get access or gain access. And it's gone the other way. Now,
it's gone the other way, yeah.
I understand that the reimbursements are kind of rising on the Medicaid side, but still there's a stigma.
The reimbursement's enough to pay for your office overhead. So essentially the doctors are taking care of the Medicaid patients for free.
Right.
And that's why I think we could do a lot better if we had a system where let doctors donate their time.
Right.
And don't try to pay them. And if they did it in non-government free clinics, they wouldn't have to pay the overhead over there because that's all private, just donations.
Right.
At our clinic, we can provide care for $15 per patient visit because nobody's getting paid.
Right.
And therefore, It's amazing how the kind and compassionate volunteers that are there do meet the needs of the poor. It'd be good to have somebody that could take care of the medication, and that's where Medicaid does do a good job.
Excellent. I am here with Dr. Alieta Eck. We're talking about Medicaid and kind of narcotics and pain in general management of the system. So when we come back after these messages, we're going to dive deeper into Dr. Eck's ideas of how to fix this. Talking about how to improve Medicaid and how to get people better care for less money. Quite honestly, at the end of the day, that's exactly what we're talking about. And in the first segment, we were talking about how Medicaid, it's very hard to be on Medicaid because specialists in primary care, but in particular specialists, really don't accept Medicaid. And they turn to alternate means to ease their pain. And then we were talking a little bit about your clinic and how you're able to really efficiently and effectively treat people for about $15 a patient, which is amazing, right? It's less than a traditional copay.
That's right.
So somewhere in between, right, there's the answer of how to do this. And I know that this has been a passion of yours because you're a frequent contributor. And can you tell us a little bit about that?
I was down in Washington, D.C. last weekend. We had a meeting of the National Physician Coalition for Healthcare Policy, chaired by Congressman Pete Sessions. And I presented this plan, and they said this would be good. It's a local plan, and what it is, and because all healthcare is local, think about it. We don't really need the federal government doing healthcare.
Right.
What we should do is have local healthcare. But for those who can't afford it, if we had lots and lots of non-government free clinics, and I'm telling you, there are people that would volunteer. They're wonderful volunteers that help in these kind of clinics. Or you pay some of the members, but then you just have to raise more money. Sure. But that's all right. Anyway, you want to have a lot of free clinics located throughout the state, or within a hospital. There could be a free clinic where the doctors could donate their time.
Right.
And our plan, which is S239, waiting to be heard before the Senate Health Committee, is that doctors donate 4 hours a week in or through a non-government free clinic. And instead of trying to pay us, why don't you just protect us and give us the malpractice coverage that you give to the doctors who work for the medical schools? Only cover our private practices. The federal government covers the clinic.
Right.
So now just extend the other. The taxpayers would win huge because right now what's happening is the federal government is spending billions of dollars to make millionaires out of the CEOs of insurance companies and hospitals.
Right.
And all the executives that get well compensated. But the taxpayers are getting fleeced, and the poor are just getting very inadequate care.
Right.
What's wrong with this picture?
Exactly. And I think we did the math, right, where we said that if you assume that a physician is net earning $100 an hour, the cost of their free labor will more than offset the cost of the insurance. So it's a win for the physician to do the volunteering.
It's more than just the money. Because some of the specialties are not paying that much in malpractice premiums, but it's more the ability to solve the problems, which we want to do. We want to be doctors, and this would free us up to really solve problems.
Right.
If I had an orthopedic surgeon, we would take care of that fellow with the knee. And if I could work with neurosurgeons, they paid a lot of money in malpractice premiums, so they would be happy to do this. I'd work with them, and we'd find somebody to help this woman with a jaw problem.
Right.
And just time after time, there's people that are they have bad backs, really bad backs. They need pain control specialists that can either put a vibrator type thing into the back or whatever means they use.
Sure.
Really
which may actually be non-opioid based.
Absolutely.
There's plenty of solutions that pain management doctors can do that aren't, here's a prescription.
That's right.
But they have to know that, actually get to know the patient.
That would be a tremendous solution. I'm telling you, the doctors, we pay a total of about $300 million in malpractice premiums, and you compare that to $15 billion we're spending on Medicaid. You know, the math really does work.
Absolutely.
That we would, and not every doctor would do it. So it's not that it would cost the state $300 million. It would cost a lot less.
Absolutely. And the state actually, right? If you think about it, depending on how they structure it, they may only be adding a few extra attorneys into their malpractice.
Just to defend the doctor. So now when somebody wants to sue a doctor who's a volunteer doctor, They have to sue the state of New Jersey. And what that really means, though, is that's a really legitimate case. It's not an easily defensible case,
Right.
which are just rampant in the current system.
Sure. And then for me, from my perspective, right, you think about goodwill, right? So health systems, they have very little goodwill
Yes.
right now. So if they worked with local communities to set up these free clinics to get people that need the help to get the help, there's so many good things for them, right? Aside from the goodwill and the community involvement, they're going to see fewer readmissions, right?
That's right.
So they don't get paid on readmissions. So if you don't want to get paid on readmissions, stop the problem. Have people go to your free clinic. Have them come every day if they need to come every day.
If they have to, sure.
Right? You enable to become part of the community. It's a lot better to have, say, a church organization that has a clinic and they have members of their congregation and everything funding it to say, and Virtual or Cooper here in South Jersey are part of that because
Right.
they're sending their docs there to care for these people. That is to send them a check so that they put a sign on the outside of their building, right? Like,
That's right.
What's a better way of showing that you're part of the community?
And the hospitals, hospitals get tax exempt status. That's another big issue because when you think about it, they're getting paid for everything, supposedly.
Right.
And where are they contributing? So if they had set aside rooms where the doctors would be volunteering, now they would be part of the solution, and
Right.
perhaps they could earn their tax exempt status once again.
Exactly. And at the end of the day, they're probably making more money.
Probably, but you know what? The economy will start to flourish.
Absolutely.
And we'll just as people are taxed less, and then more and more people will be productive. They won't say, "Oh my goodness, if I get a job and I earn a certain amount of money, I'm going to lose my Medicaid, so
Right.
I don't think I want to work."
Exactly.
And there actually is that mentality out there.
Sure. Well, we definitely want to talk about that in the next segment. I'm Jim Cuccinata. I'm here with Dr. Eck. We're talking about Medicaid, and we're specifically talking about a bill in New Jersey that's being introduced. So when we come back after these messages, we're going to continue with the solution. We'll be right back. I'm Jim Cuccinata. Welcome back to Morning Coffee. I'm here with Dr. Eck, and we're talking about Medicaid reform. This was a high level of what we've evolved into our conversation. And in the first segment, we were talking about how Medicaid kind of forces people to find alternate ways to care for themselves. And then in the second segment, we're kind of talking about the solution. And we took a break really at an interesting part, right? Because we were saying that if you push the quote Medicaid care out into a volunteer force, and you start building jobs and esteem around this care, right? We're going to see an economic benefit.
Sure. I think if we, anytime you free up the taxpayers where they have to pay less, you're going to increase economic activity where you want it. And
Right.
so that's a good thing to happen. You have to understand the Medicaid also pays for people in nursing homes, and we're not talking about that.
Right.
And there's a lot of disabled children that need help, and obviously they need help. And
Sure.
so we're not talking about that either. What I'm talking about is the ambulatory population, which has surged under Obamacare because everybody was forced to buy insurance
Right.
or get onto Medicaid. Medicaid expansion in New Jersey has been very big. In the ambulatory population, these are people who are not sick.
Right.
And so the taxpayers are paying at least $5,000 per person going to a Medicaid HMO for people who don't need medical care.
Right.
Now, what is wrong with that picture?
Sure. Right.
So-
It's not use based, which or
Right.
activity based. It's
Right,
spreadsheet based.
right. And that is how people are going to die if you end this, and that's just nonsense.
Right.
They're not going to die. They weren't dying before we had Obamacare because we do take care of people who are critically ill
Right.
when they go in the hospital. And even Medicaid does that. If somebody comes in with a gallbladder that's burst, they get taken care of.
Right.
If they have a gallbladder that is just kind of festering and causing pain, but no liver enzyme elevations or fever, they're sent out, say, go find a surgeon.
Right.
And they can't.
And then until they come back and it's first, and then you've got a
But- yeah,
bigger
right.
issue.
Right, and it's a bigger issue, it's
Right.
more expensive, and it's really a crazy way of doing healthcare.
It really is. And then one of the things that at least comes to my mind when you think about economic benefit is you have an aging population, which means you have lots of doctors and nurses and other medical professionals. They're kind of retiring. 4 to 8 hours a week probably could do a lot of good for them. It could do a lot of good for them. It does a lot of good for the community. Again, you're building local bonds and ties. And
Absolutely. We just have a brand new volunteer in our clinic, the Zarephath Health Center, and he's an internist who just retired and didn't want to stop.
Right.
And so, of course not. And he's wonderful.
Sure.
He just really knows medicine, and he's been taking care of just patients that come in. The nice thing is that the patients are so grateful because they know we're volunteering, and there's just a lot of goodwill that happens.
Absolutely.
And they're welcomed into the clinic. The volunteers are wonderful to them. It's not a cold kind of perfunctory clinic. Instead, it's just a place where people come to hang around.
I was going to say it's a place to hang out, and for you guys, right? That's 4, 8, 12 hours a week. You now are free, and this doctor probably knows 2 or 3 other doctors that are in the same boat that he's in, and
Sure.
now you may have full-time service in a free clinic that you're now, instead of helping, I think the number was 12,000 people a year, it's 18 or 20,000 people.
We're only open 12 hours a week because of our inability to find enough doctors to man it.
Right.
And my husband and I each do 6 hours, and we're like the default physician.
Right.
We can't do more. We have to earn our living elsewhere.
Exactly.
So if we had every doctor volunteering of all the specialties, the camaraderie, and let's get this solved, and you would just it's the way it used to be.
Right.
And before the government got involved and said we're going to pay for everything.
Sure.
With Medicaid, and I'd love to get back to that.
Excellent.
Everybody would enjoy being doctors again.
Good. Before we go, do you have any last message you want to give to anybody?
Okay, I would just like to say that New Jersey S-239 is the bill that we're looking at that would just open us up to having free clinics all over the state. And other states are actually looking at this idea. So what we need to do, though, is get Senator Vitale to bring this before the Senate Health Committee so that we can discuss it and discuss the merits of it and figure out how this would really make healthcare better in New Jersey. We'll save our New Jersey economy, frankly.
Excellent. I'm Jim Cuccinata. I was here with Dr. Alieta Eck, our Medicaid expert of all things. We can't wait to have you back on. And we will be back to morning coffee after these messages.